and other biological markers. Comprehensively, all of these three levels put together will allow us to have a very good overview of the entire risk associated with NCDs in this population. In addition to the multi-level data collection, we also will be providing community benefit to all of our participants through engagement, continuous engagement and education. And one of the unique features of this particular cohort is our partnership with the Jamaica Northeast Diaspora Health Sector, where they will be joining with us to be involved in the community engagement aspects of our study through education and empowerment of our cohort participants. Because ultimately what we do want to achieve is that our participants will live indeed in full health. Next slide, please. Another interesting feature or unique feature of this cohort is our integration platform, which we have designed and are continuing to build on. This integration platform will allow us not only to be able to analyze the data from the Jamaica cohort, but it will also allow us to integrate other data from other populations, particularly to mention the CAP3 data, which is the data on the US side. This is the data that involves participants in the US who are immigrants, Jamaican immigrants and other Caribbean immigrants, as well as African Americans. We have harmonized our tools so that all of the data that's being collected is collected in the same way. And this will allow us to be able to integrate our data for further comparative studies. Our integration platform is also designed to be able to integrate not only with the CAP3 data in the US, but also other Caribbean data sets from other cohort studies that may exist within the region. This will allow for much broader impact, not only for Jamaica itself, but for the region and also across the different populations on different continents. Because through collaboration through the AC3, which is our consortium within which this study is based, we have other investigators across the region that are doing other work, which will be able to harmonize with the Jamaica cohort. So this integration platform will be very valuable that will allow for even much broader impact. And this will be achieved in the next slide as I describe to you our framework for the collaborators that will contribute. Next slide, please. The AC3 is a well-established network for the past 15 years and involves many, many investigators across the Caribbean region. The lion's share of the investigators are there in Jamaica, hence the reason for establishing our cohort study here first. However, there are other studies that are ongoing in the Bahamas and in other islands within the region and also in the United States. And AC3 also has partners and members in other African countries. And one of the ways that we hope to collaborate is to be able to compare our populations on the continent with the Caribbean populations, as well as the US populations, the Black populations in the United States. So all of this will be achieved through the integration platform that we have developed. And so we look forward to this larger impact that will be realized from this study. Next slide. Thank you very much for your attention.
So thank you very much, Professor Rajan, for giving us that excellent background to this study. And certainly it looks exciting. And I really do hope that we achieve all that this project sets out to do, and certainly will have a major impact on the population's health. So our next presenter is Professor Marshall Tully-Reid, who the LIFE project. So Professor Tully-Reid is a physician and endocrinologist, and he is the director of the Caribbean Institute for Health Research at the University of the West Indies. He obtained a Master of Philosophy degree in epidemiology from Cambridge University and Doctor of Science degree in epidemiology from the Netherlands Institute of Health Sciences. Dr. Tully pursued training in internal medicine at the Howard University Hospital in Washington, D.C., and subsequently trained at the National Institutes of Health Inter-Institute Endocrinology Training Program in Bethesda and also in Phoenix. He is a fellow of the American College of Endocrinology since 2005. Professor Tully Reid joined the staff of the Caribbean Institute of Health Research in 2003 and has published several papers on obesity, diabetes, cardiovascular disease, and prostate cancer. His current research projects involve evaluating factors for type 2 diabetes and cardiovascular disease, and also looking at endocrine disorders in prostate cancer survivors. He is co-PI of the LIFE project, which he will tell us a bit more about in terms of the objectives, etc. Let's welcome Professor Tully Reid.
All right, thank you very much, Dr. Ferguson. I think I can be seen from the camera. All right, so all protocols observed, and because we're a little behind time, we'll just go straight into the LIFE project and giving you a little bit of an overview about what it is that we're planning to do. So you want me to share from this screen? Okay. So these are some of the data that the minister had alluded to earlier. This is data from the 3rd Jamaica Health and Lifestyle Survey and looking at obesity by age and sex. And as he mentioned, you can see that there's a high prevalence of obesity, particularly in women compared to men. In the next slide, you'll also see some other data from the lifestyle survey looking at diabetes. And what we see here again is a female predominance of this disease and an increasing prevalence or number of persons who have this condition as people age. The third slide is also from the Jamaica Health and Lifestyle Survey, and this looks at hypertension. The minister also alluded to this as well, in terms of the fact that so many persons in Jamaica have hypertension. These are all data that we can look at and see that there is a problem with non-communicable diseases, and it also raises a number of questions for us in terms of the reasons why we are seeing some of these patterns. Why is it that there is a predominance of obesity in women compared to men? Why is it that these diseases are increasing with age, or why are they occurring at such a young age in our population? The next slide also gives you some other food for thought, which is data from the statin. And this is looking at the main causes of death in men and women. So a lot of us are concerned about violence, and I think with good reason there's concern in men. But what you'll look at in these slides is that most of the causes of death are actually not from violence, but from non-communicable diseases, both in men and women, especially when we combine these things like cardiovascular disease, diabetes, and hypertension, and cancers. You can see that these will outweigh violence or motor vehicle accidents quite dramatically. So one of the reasons why we decided to undertake this study was to try and understand why are we seeing this pattern of diseases. And cohort studies are actually a unique kind of study. Most of us in Jamaica are accustomed to surveys, which is a one-time questionnaire or measurement, and that's the end of it. But cohort studies are actually follow-up studies. And these are very powerful tools when it comes to research because they allow us to understand the reasons why we see things. So we identify people who may have some conditions or be at risk for conditions and follow them over time to see whether or not they are at higher risk or things change. And this provides the best evidence that we need to help to develop things that can be used to prevent and manage disease well, and not just one condition. So the next slide really talks about why Jamaica, and I think Dr. Reagan put it quite well. One is that we have a very strong tradition of cohort studies, and I don't know if any members of the public would have been part of the sickle cell cohort study, which is a very famous study that was led by Professor Sargent, which transformed the way in which sickle cell disease is managed worldwide. And we've had other cohort studies as well on infectious diseases like HTLV1, and then those who were part of the Spanish Town cohort study back in the 1990s may remember that study looking at risk factors for obesity and hypertension. But Jamaica is also one of the countries where you have a high burden of non-communicable diseases, which you saw from the slides before. And it's of particular interest because of our highly migrant population, where Jamaicans are a large proportion of our Black diaspora. On the next slide, you will see what we are planning to do with the life study. So one of the things, we have really three objectives for this study. One is that we really want to begin to engage people better, and that's one of the things we're doing with this public forum, to encourage them to be part of this study because of the potential impact it has, not just on lives in Jamaica, but around the world. And one of the things that makes a cohort study very helpful or useful is when we're able to follow people over a long period of time. So we want them not just to be part of the initial wave, but to continue to engage with us and give us information over time to see whether or not certain conditions develop. And of course, in doing this, we're building on the work and the partnership that we have had with the Ministry of Health in conducting the Jamaica Health and Lifestyle Surveys. And actually, it was the third Jamaica Health and Lifestyle Survey which was able to show for our international funders our capacity to carry out this kind of research. And so we want to move the Jamaica Health and Lifestyle Survey from what it was, about a 3,000-person island-wide survey, into an 8,000-person survey. And of course, as Dr. Reagan would have mentioned, the benefit of research is not just for Jamaica. It's going to benefit Black populations throughout the world. And so our ability to compare our findings with those in other Black populations in Africa, in the Caribbean, in the United States is very powerful because it helps us to understand the reasons why we're seeing differences in the diseases and disease patterns around the world. The next slide just tells you a little bit about what we're planning to do. And as I said, it's an island-wide study, which is sometimes you might say a bit ambitious. Most times when we're doing these kinds of cohort studies, we'll just focus on one geographic area. Persons who are part of the Jamaica Health and Lifestyle Survey to get our numbers up to the 8,000. We're actually going to be inviting other persons who are in those communities to be part. A little bit about what this study will involve. Because non-communicable diseases are so unusual, and not so unusual, but just so difficult to understand, we have to look at so many aspects of health to try and understand what is driving the high levels of non-communicable diseases in the region. And when we talk about non-communicable diseases, we're talking about our cancers, which everybody should be familiar with, cardiovascular diseases, which include hypertension, as well as heart attack and stroke and diabetes. And so there'll be a detailed question, so don't be distressed when we ask you a lot of questions, but it's because there are so many aspects of life which can impact our non-communicable diseases, what we eat, where we live, how we feel, our family history. All of these we'll try and capture with this very detailed questionnaire. We're also going to be asking for biological specimens, and these will include blood, urine, nail clippings, and saliva, as well as hair. People may ask, why are we collecting other things? We normally just collect blood. But there's reasons why we want other specimens. Urine, for example, is one way of our identifying exposure to cigarette smoke, which you'll have seen from Professor Reagan's talk is a very important risk factor, not just for cancer, but for very many cardiovascular diseases. Hair and nails are important because a lot of the toxins that we're exposed to in our environment build up in these tissues. And so when we take nail clippings or hair samples, we're able to look at your exposure to potential pollutants or toxins over a longer period of time because these may not be in the blood for long. And all of this will help us to understand what are the things that are driving the high burden of diabetes and heart disease, stroke, cancer in our particular societies. And of course, if you become part of this cohort study, we're not just asking you to be part of a one-time survey and then that's it. We actually will benefit the most when we keep in touch. So your ability to keep informing us of what is happening and letting us know if you've developed any of these conditions is really what is going to help us to understand the reasons for these diseases. So participating will help. We hope it will help you to understand your own health. And we've had participants who have said that just being part of these studies has helped them to understand more about their own habits and hopefully help them to change. The things we're collecting will allow us to identify new things that can help us to pick up diseases early, maybe new ways of detecting cancer or heart disease. It will also help us to know how to treat these conditions better because the research that we do now will form the basis for things that you'll see later. And people ask about why the vaccine has come out so quickly for COVID-19 is because they've been doing these kinds of studies which have form the basis for a lot of the things that they have done. And of course, we hope that it will inform, as the minister has said, prevention and treatment guidelines for not just Jamaica, but for the world. So, COVID-19, why are we here? Well, we're here partly because we're not able to visit you in home as we normally do. Normally we go face-to-face and knock on your doors and encourage you to be part of the study. But COVID-19 has changed all of that. And so in the last few months, we've actually had to redo our entire project in terms of the ways that we were going to engage and trying to get people to be part of a study. So we're not going to be doing face-to-face interviews. Maybe in the future that will resume. But for now, most of these interviews will be done by telephone or by Zoom. And we've also included the option of self-completion of some of these questionnaires by participants. The measurements are going to be done primarily by UWI full-time staff, which is a very different experience for those who are part of the previous Jamaica Health and Lifestyle Survey. And this is because we don't want to overly expose persons to the risk of COVID-19. And also we'll have appropriate PPE and precautions and sanitations, which will make the whole idea of meeting together and collecting these measurements a lot safer. And then, of course, instead of our community engagement activities, which would be happening at a local level, we're actually going to be doing a lot of online meetings. So for those who haven't learned how to use a computer or their phone, you're going to get a lesson through this study. So you learn more about not just your health, but how to use your computer. So our investigators are listed here. In addition to myself, we have our statistical support from Dr. Younger-Coleman, Dr. Ferguson, who's chairing, Dr. Gavaya, our psychologist, Professor Wilkes, who's the founder of the Jamaica Health and Lifestyle Surveys, Dr. Marshall, who will be working on the genetics and biology from Jamaica, Professor Hambleton in Barbados, who has a lot of experience with cohort studies and surveys, and then our other team members, Professor Reagan from Fox Chase Cancer Center and Professor Ashing from City of Hope Cancer Center in Los Angeles. And of course, there are other members of the team that those who participate will get to meet. On the next slide, I won't name them all, but you can look out for them, so these names won't be unfamiliar to you when they try to make contact, along with other members of our study team who have worked with statin and have been in the communities before. So the last slide is really just to kind of show you, this is what our logo is based on, the baobab tree. This is a tree that is found in Africa. And we think it's appropriate because the work that we're doing is not just related to Jamaica. It's going to impact the whole diaspora, from Africa to the Caribbean to the United States. It's a tree that survives even in the middle of hardship. It's found in the most arid conditions. It has very deep roots. So in other words, looking at it, you can see us going right down into understanding what's going on, from the biology to other things that result in disease and health. And we hope that the legacy that we leave behind, not just for ourselves, but for our children and the world, will be one which will allow them to live in full health as the name of our project states. Thanks very much.
So thank you very much, Professor Tuller-Reed. And again, as we get more details on the project, it certainly continues to sound very exciting and promising. And I'm sure that we are better informed and stimulated as to the potential for this project, and certainly for community members that you're fully engaged and ready to participate. Now, we're a little bit behind our schedule, so we're going to move into our question and answer session. So this will be done through the Zoom link. So participants on Zoom, you can indicate if you have a question, and our Zoom moderator will let us know who has the questions or comments. Our presenters should be available to provide answers to your questions. And we'll probably limit this to about 10 minutes given the time constraints, and of course, so as to not to take up too much of other commitments that persons may have. So, okay, so I'm advised that the minister had to leave. Of course, we really want to thank him for his contribution to the morning's proceedings, and certainly we look forward to continuing to work with the Ministry of Health in this project and many other projects. All right, so while we wait the questions, I will probably start with one, and I was particularly intrigued when Professor Regent spoke and showed that diagram looking at the differences in mortality for cancer across for US-born versus immigrants versus Caribbean-born persons. And I just wondered if we had data on incidence and whether the incidence varied similarly, and also whether this suggests that this may be related to issues such as access to care, or are there environmental factors or genetic factors, and will we be able to answer some of these questions through the LIFE project? So, Professor Regent, I trust you're able to hear and answer.
Dr. Ferguson. So to answer your question first, is there data on incidents? Well, that is one of our biggest challenges, because especially in the Caribbean, there is very little data on incidents for the region. There are not many cancer registries that are well established. But of course, in Kingston and Jamaica and across the island, we do have some level of data with regard to incidents. In the United States, similarly, there is a challenge, because the cancer registries in the US do not regularly complete information or collect complete information on the country of birth. And so oftentimes when we look at that data, it is so incomplete that it is not possible to be able to calculate incidence according to subgroups. However, there is data for mortality, because we do have the ability to cross-reference with death records, which always has the country of birth. So we have published, our collaborators have published a number of studies looking at mortality. What we have found so far in these studies is that there is indeed a difference in mortality rates between immigrants and African Americans. Immigrant mortality rates are actually lower than African Americans. Why there are some of these differences? Obviously, we don't have all the answers yet, but some of the work that we have done already has suggested that there are very clear differences in behaviors, clear differences in perceptions. Smoking, tobacco smoking is one very big difference. We do see that between the subgroups, and there may be others. And there may also be some genetic differences based on studies that we have seen coming from the Caribbean region, where there are some Caribbean countries that have higher genetic risk factors for certain cancers. And we believe that that may also attribute to differences in risk in the United States. But these studies need to be done, and that's one of the reasons why this cohort study and others are so important.
Look forward to the data that should come out of this study and to try to help us to tease out some of these questions. So there's a question from the online forum asking, is the questionnaire available for persons to view content? So I'd probably ask Marshall to give a response to that.
At this point, it's primarily available for the participants, but if somebody is interested in collaborating with us, they can make contact and we can discuss how the questionnaire can be shared.
All right, so, all right, yes. So the next question says, how will the project facilitate cohort members who migrate from Jamaica to the US during the course of the study? So Marshall, you probably should stay nearby.
6 feet away. Plus I was 6 feet away. All right, good. So, so for our study, we're actually, because it's a follow-up study, we're interested in people who are not likely to migrate in the immediate future, that we can have some ability to follow them up over time. But if people were to migrate and unexpectedly, then I think we would be able to accommodate them, because what we're actually interested in is some of the information on their health over time. Some of this may just be things that they can answer by questionnaire, and if they visit, they could also participate in other ways by giving specimens or other samples that they want to donate to the study.
Okay, thank you very much. Do we have another question? All right, so comment from, I think this is Professor Samuels. So migrants are self-selected and likely healthier and younger than the underlying population. Okay, so thank you very much, Professor Samuels. Did you want to make another comment? Marshall is there. Go ahead, Marshall.
Yes, and I think that's one of the reasons why we actually do want to engage people at every level of society for this particular study. Very often we know that there's a little bit of bias because people who migrate are more likely to be better educated, maybe better able to work and help themselves, and that's the reason why they're popular. When we do this kind of research, a lot of times we only engage some members of the community, and we're actually trying to engage a wide range of members of the Jamaican community, not just those who could potentially migrate, but those who are well established here. And this is very important because one of the things that we're trying to look at is the role of place on disease. So we know that there's a high burden of these non-communicable diseases in Black populations. In other settings, this is because of the environment, racism, as we have seen with the Black Lives Matter, does that put a lot of stress and make people eat more or gain weight or become hypertensive or diabetic or get more cancer? Or is it really just something that is genetic, inherent in being part of the ethnic Black population? And some of these we can only tease out when we are comparing populations across countries, when we are measuring some of these biological markers to know whether or not it's a biological effect or an environmental effect, and when we get a range of persons participating in the study, not just volunteers, which is why we're actually going out of our way to invite persons in a sort of non-biased way to be part of the study. So we know a lot of times when people volunteer for projects, they're more healthy and may have different characteristics. But by going house to house and giving everyone an opportunity to be a part of it, we're hoping to get around some of those things that might make the issues less clear. Also, by going to all parts of Jamaica, we'll be able to have hopefully some range of differences in people's experiences, and that will also be helpful for us to understand what is driving a lot of our non-communicable diseases in the region.
Okay, so thank you very much. Do we have another question? I see something in the chat. Oh, it's just another comment. Okay then, so, well, it's 10:55 and we were scheduled to finish a little bit before this, so I will wrap up. I presume I can demask. So let me just use this opportunity to say a very special thank you to the organizers of this launch, to the Professor Tully and his team, those who worked behind the scenes in terms of all the LIFE project staff members who have really put a lot in organizing and putting this meeting together. Certainly to our presenters, the Minister of Health, Dr. Tufton, to Professor Rajan and Professor Tully, as well as persons who have participated in asking questions, etc. Also, of course, our Dean, who has been with us for the entire session. We really want to say a very special thank you. We want to say thanks also to our support team, or audiovisual personnel, for ensuring that we have this being able to be live streamed, and of course that everyone can participate despite the restrictions based on the COVID-19 limitations. So then, I think that we have had a good morning, and we have learned quite a bit, and therefore I just want to say thanks to everyone, and I guess that's it. I think there are, well, yeah, that's it from me. Thank you very much. Marshall, any parting comments? No? There you go.
No, I mean, I think that is it. Thanks everyone for joining us and for being part of our virtual launch. We especially thank the UWI's regional headquarters and their staff for accommodating us. Our marketing manager, who is managing our Zoom, Mrs. Snooks, and the technical staff from the community project who have helped to facilitate this broadcast. So all the best until we see you in the field or online. Thanks very much. One of the reasons. All right.